Yes, perfect.
Good evening, everybody, and welcome all of you to the 60th live webinar on orthopedic principles. This time, our guest of honor is Ms. Sally Hobson from Hull, United Kingdom. Ms. Sally was appointed at Hull Royal Infirmary in 2012 as a consultant orthopedic surgeon, following a fellowship in pediatric orthopedics at the Children's Hospital, Westmead, Sydney, Australia. Her clinical practice includes adult and pediatric trauma, along with elective pediatric orthopedics. She supports York Hospital with on-site collective pediatric orthopedic clinics and day case operating. She's a fellowship examiner and is renowned for her commitment to training. She was the winner of the British Orthopedic Trainees Association Trainer of the Year Award in 2020. So today it's my honor to invite Ms. Sally Hobson for this lecture on slipped upper femoral epiphysis. Over to you, Ms. Hobson.
Thanks ever so much. So I'm talking on slipped upper or capital femoral epiphysis. The content's fairly standard, really. So talking about the definition and the pathology, a bit about how these patients present, what investigations we do, and the classification, how we treat it, and most importantly, what potential complications there are, as this is a diagnosis where there are a number of associated complications we'd like to avoid. So a slipped femoral epiphysis is basically, it's like a Salter-Harris 1 fracture through the hypertrophic zone of the growth plate. The femoral head obviously stays within the acetabulum, and the femoral shaft rotates away from the femoral head in a superlateral direction, which is what creates the external rotation deformity and shortening in a severe slip. So in general, the age group affected are between the age of 9 and 13. You can obviously expand that age range, and it does happen younger in girls than in boys. About a third of cases are bilateral, not necessarily at presentation. It may be they get a slip on one side and then potentially a subsequent slip on the other side. So it does occur during the prepubertal growth spurt. So what happens is that the child is doing lots of growing, lots of growth hormone there, but the sex hormones haven't kicked in to promote fusion of that growth plate. So it's particularly vulnerable at this particular stage. And that's why it tends to occur younger in girls than in boys who reach maturity sooner. It's also affected by the shear forces across the physis. So it's felt that if you've got a more vertically oriented physis, that you're more likely to be vulnerable to those shear forces. So classically, it's described as happening in an obese child, but that is certainly not always the case. And I certainly have seen children that are underweight with it, and certainly not always obese. So just be wary of that. There are a number of metabolic and hormone-related conditions that are associated and put people at risk, such as hypothyroidism, Cushing's and rickets. And then there's also problems with the connective tissues, so Marfan's or Down syndrome or irradiation or a history of chemotherapy that predispose to this. So the patients usually, in the majority of cases, present with some degree of chronicity. So frequently, I'm sure we'll all have seen patients like this where they may have had a history of going to their minor injuries unit with a bit of a groin sprain when they've been playing football. They can be fairly innocuous symptoms, and when they stop exercising, the symptoms can settle down. Therefore, people think that it's not necessarily something too worrying. Generally, the pain is either in the groin or in the knee, but it can be very vague. It can be in the thigh. I've even seen an adolescent who had a bit of back pain with it as well. So it can be quite atypical, and it's just about having that degree of suspicion in a child of the right kind of age. When you examine them, the hip may be irritable, but this really depends on the severity again. A very mild chronic slip may be almost normal to examine, whereas obviously an acute unstable slip, the leg will be short, externally rotated, and they'll be in a lot of pain with restriction of movement. So the only investigation really that you should need would be an X-ray. And the frog-lateral X-ray is the most important because it's quite easy to miss on the AP X-ray. On the AP, you can, if you look carefully and compare to the other side, assuming it's normal, see some widening of the physis. And this here's a good example. So this is the AP X-ray of a child with left-sided knee pain. And I think you can see, if you just compare the physes here, you can see it's nice and normal and narrow on the right, but it's quite wide on the left. Now, it's hard to appreciate any kind of slip if you look at that standard line up the femoral neck, but you can certainly see that widening of the physis. And then if we look at the frog-lateral X-ray, you can much more clearly see that slip. So that's why it's so much more obvious on the frog-lateral. And I've certainly seen patients who have been missed who only had an AP X-ray. I mentioned that line along the superior border of the femoral neck called Klein's line, and we're looking for that to intersect the femoral epiphysis. And if it misses, then it's suspicious of a slip. And on the image on the left, you can again see those yellow arrows pointing at the widening of the physis in association. In a patient who's got a completely normal X-ray, but you're clinically still quite suspicious, then you should think about doing an MRI, as these may be very sensitive to pick up a very early slip. In some units that have particularly fancy MRI scanners, they can use MRI pre and post-operatively to assess the vascularity of the femoral head, but not all centres have got the right kind of scans to be able to accurately assess that. So the classification, I mean, I quite like the classification for slip femoral epiphysis, the clinical one, because it's nice and obvious and straightforward. So Loder's classification, you've got the patient who's walking around with just a little bit of pain but can still wait there, who's got a stable slip, versus the patient who's in a lot of pain, who can't wait there, and they have an unstable slip. And we know that if you've got a stable slip, your rate of avascular necrosis is tiny. And if you've got an unstable slip, your rate of avascular necrosis is potentially very large. The quantitative measure is the Southwick angle, which often confuses people. And basically, this is taken by a line perpendicular to a line taken from the apices of the physis. You draw that line perpendicular to it, which is line B, and then line C is a line just really subtended from the femoral shaft. And the angle between for the normal hip is deducted with the angle on the abnormal hip. And the difference is the Southwick angle. So you can see for this patient, they've got 40 degrees on the abnormal side, and they've got 12 degrees on the normal side. So their Southwick angle will be 32 degrees, which puts them just into the moderate category. So the first thing to say about treatment in these patients is that they need to be on bed rest until they have an operation. Now, if you allow that child to mobilize with crutches, non-weight bearing, and they have a little stumble at home or on the ward and convert their stable slip into a severe unstable slip with a much worse prognosis, then really that's not terribly defensible. So you really must put them on bed rest until it's stabilized. Your gold standard answer in an exam should be in situ fixation with a single cannulated screw. And that is your safe answer. So you need to remember that your entry point is anterior. So you can see in this image why a C is in the correct place. What you want to see is that angle taken as we did when we measured the Southwick angle. We drew that line from the apices of the physis. And we would like that wire or screw to go as perpendicular to that line as possible. And we want it in the center of the femoral head to reduce our risk of pin penetration. You'll see if you put your wire where a standard DHS wire would normally go, then it will go nicely up the center of the femoral neck, but you will not hit the right place in the femoral head. So the entry point is completely different to what you're used to if you're doing lots of DHSs. You need to screen through a full range of rotation when you've inserted your wire, and particularly when you've inserted your screw, to be 100% sure that you have not penetrated the joint. And generally, I would recommend not removing the screw at any stage. So once the physis is fused, the screw has done its job, but it can be very, very difficult to remove. So I don't recommend doing that routinely. So this is just an example. It's a fairly easy one to get in the right place because it's a fairly mild slip, but we can see that the screw passes nicely perpendicular across that line of the physis, and it's in the center of the femoral head. You'll note that we've got a really nice AP image and clearly a very perpendicular lateral X-ray. So we've got some nice orthogonal X-ray pictures to reassure us of no screw penetration. Now, severe slips can be a slightly different kettle of fish. And I would recommend that you would certainly discuss a severe slip with a centre or a specialist who is very familiar with them. You've got three options. So one is to still pin it in situ. Now, in some really severe slips, this just technically is not possible, such as in this image shown here. It's such a severe slip that your position in the femoral neck wouldn't have enough purchase to hold it. Now, some surgeons look for a gentle allowed reduction. So what this means is when you gently put your patient onto the traction table, you don't apply any traction, but you just gently internally rotate the leg into its correct position. And sometimes that will then fall into place, particularly if the slip is very acute and very unstable, it will just fall back into its position. And then that will allow you to pin it in situ. The final option is to do a bigger procedure to actually create or restore an anatomic reduction of that slip and then secure it. And this can be done in different ways. So you can do an anterior approach and take an anterior wedge from the femoral neck, such as a Dunn osteotomy, or you can do a Ganz surgical dislocation, which involves a trochanteric osteotomy in order to try and preserve that blood supply. And the concern there is that if you're not used to doing these procedures, that you may end up creating AVN in these patients who are already at quite high risk of it. And I would exercise caution if you're ever reviewing literature about any of the surgical outcomes after slips, because you must ensure that you're comparing like with like. In a patient who's got a severe unstable slip, their AVN rate's really, really high, maybe 40% or more. In a patient who's got a mild stable slip, they've got a negligible risk of AVN, and therefore your surgical outcomes, it depends on which of these patients you're choosing to operate on as to what you're comparing the outcomes to. So just a word of caution there. And I know this isn't relevant to everyone outside the UK, but within the UK, there's some nice guidance, which again, just emphasizes the need for this to be something that's done by people that have got specialist training and support and are monitoring their results carefully. So it's worth talking a bit about contralateral fixation. So we talked about the fact that there's an incidence of 30% of bilateral slips. And how do we know that our patient with a unilateral slip isn't going to go on and slip on the other side? So you've got the argument for doing prophylactic pinning. Now, weighed against that, the risk of having a slip if you don't do it, are the risks of actually doing an operation on an otherwise normal hip. So some people take the approach that they want to fix all prophylactically, and that's a perfectly reasonable approach. Some surgeons choose to do selective prophylactic pinning. So considerations in that regard or if you've got a patient with risk factors. So say a patient who you know's got hypothyroidism, clearly you're going to be at risk of bilateral slips, and it'd be a good reason to pin theirs contralaterally. Younger patients, if you've had a slip at a very young age, it's going to be a long time before the physis fuses, and therefore they're at risk on the other side for longer. Compliance, if you've got a patient who you can say, if you get any symptoms at all on the other side, please come back quickly for an X-ray, then that should prompt you to think, well, maybe it'll be safe to leave them. But if you've got someone that you can't reliably expect to listen to their symptoms and wouldn't attend reliably, you may be safer prophylactically pinning them. And the final thing that's written about is the posterior sloping angle. And if you look again at how we did the calculation for Southwick's angle, looking at the normal side, this is what the posterior sloping angle is. And it's said that if that's over 14 degrees, then there's maybe a pretty good indication for doing a prophylactic pinning. So on to some of the complications of slip femoral epiphyses, which can be pretty catastrophic. So the first that's quoted is chondrolysis. And this is related, it's said, to pin penetration. You can see in this image on the left side that there's definite narrowing of the joint space. Now, I have to say, I've only really seen chondrolysis personally in relation to patients who've got AVN and had it concurrently with that. But it is said to be caused by pin penetration into the joint. And I'd caution you to ensure when you're using the cannulated screws that you do lots of screening as you advance both the drill and the screw over the guide wire. As sometimes if you've damaged the guide wire slightly holding it with the pin collet, when you've been advancing that, then the screw or the drill can jam into the guide wire and advance it further in. So be really careful, do lots of screening when you're inserting these. This is an example for you. It's not one of my cases, but came to me later. This obviously patient has bilateral slip femoral epiphysis, and it's the left side that we're looking at. Obviously, both sides were pinned. And basically, the images that were taken in theatre all look to be taken in a similar view to this one. So there was only AP images. I couldn't see any lateral images at all. And one of the AP images looked worryingly like this. And basically, you can clearly see that the screw is into the joint on this one image. So if you see that on any image, it is in too far and it must be backed out or replaced. So when this patient came to clinic, they had this check X-ray, and it just highlights the point of how misled you can be by an image in theatre like this that looks as though the screw's in a good place, to when it's taken in a different orientation of the leg, how different it can look. And indeed, the CT scan shows that that screw is really not in the right place at all and is sticking out the back of the femoral neck. So I took that back to theatre and revised the screw, and I highlight the fact that you can see here two very different images, the AP and a lateral view. And obviously at the end of the procedure, I also took that leg through a full range of screening rotation to ensure that it's definitely not prominent into the joint. So the real bad complication that can happen is AVN. And as I said, with those unstable slips, there is a very, very high rate of AVN, and you must warn the patients of this potentially life-changing problem. As I say, there's the question of if you've done some manipulation or intervention in theatre, was it actually the intervention that caused the AVN? It's hard to prove either way. It usually, when it happens, can be very severe, very symptomatic, and difficult to manage. So this is a 12-year-old girl who had this severe, unstable slip. And she actually underwent a gentle allowed reduction. The surgeon chose to fix this with 2 screws. Now, that was chosen because it's a very unstable slip, and this was done by a surgeon that's experienced with slips. And I certainly wouldn't suggest that you try and put 2 screws in unless you're very technically experienced at treating slips and getting those screws in the right place. So she had initially a nice result, and at 3 months, the X-ray looked really good. However, when we got to the 6-month stage, the patient had developed an adduction contracture on the left and pain, and we can see the sclerosis in the femoral head and things really not looking right. So I took her to theatre and basically did an adductor tenotomy and an EUA. The hip did move through a good range of movement after I did the adductor tenotomy, and she for a short time had quite good symptomatic relief in that regard. Unfortunately though, she continued to become symptomatic again. The femoral head collapsed further, the screws became prominent and had to be removed. She redeveloped her adduction contracture and ended up with a very abnormal shaped femoral head, and a very, very symptomatic, in a lot of pain. And she actually ended up having a total hip replacement at the age of 14 to address this. So what happens in a patient where we accept the deformity and we pin this in situ? This obviously may result in an externally rotated short-limbed gait. And there's a risk of cam impingement, where that bump, where it has slipped, can impinge. But I'd ask you to think about the fact that if you get a bit of cam impingement and potentially can do an arthroscopic bump resection, that might be a much better option than potentially damaging further the blood supply to the femoral head and causing that catastrophic AVN. Late screw complications, I'd already mentioned for the other patient when they have avascular necrosis, and that means that the femoral head collapses and the screw becomes prominent in the joint. So just watch out for that. The other thing that can happen is that if a child has this pinned quite young, then it can grow off the screw. So this is a 9-year-old boy who had a slip. It was pinned, and 2 or 3 years later you can see the physis is still open, but the screw is, the femoral head has grown away from the screw. So it's really important to catch a slip early to avoid complications. We need to make sure that we've got a frog lateral X-ray. And we need to be very careful about our screw positioning during fixation. We need to consider whether or not the patient should have the contralateral side prophylactically pinned. And we should follow up until the physis is fused, monitoring for those late screw complications. And do discuss severe slips with a specialist because of the risk of AVN versus that risk of impingement, and which of those is easier to manage. I think that's it.
Thank you, Sally, for that wonderful presentation. And I think it has been a crisp presentation looking into all the important questions that usually come up for the fellowship exam. There have been a couple of queries that have come in. I'll go through some of them. And one is, do you do a metabolic screening, a profile for patients with slip? For example, do you look for hypothyroidism or hypopituitarism or hypogonadism if you see a patient with a slip capital femoral epiphysis?
So I wouldn't do that for every patient. I would do it in a younger patient or a patient that I had clinical suspicion, from clinical point of view. Certainly the hypothyroid patients sometimes have a classic kind of, you can see clinically. So if I don't have clinical suspicion and the patient's a standard age for it happening, then I wouldn't routinely do all those blood tests. Okay.
The other one is, do you think an arthrogram is going to help you with identification of a screw penetration intraop?
Well, I have to say I've never needed to do that in terms of intraoperatively for, pinning in situ, mainly because obviously you've got quite a thick amount of cartilage on the femoral head. So you should be able to see very clearly on the X-ray where the screw is. And I wouldn't want it, if you just relied on the arthrogram, then the screw may still be within the cartilage. And really you want to err on absolutely the side of caution. You want it to be in the bone, not in the cartilage. So I don't think I'd recommend that technique, but if I guess it would be something you could have in your armamentarium.
Because there are a couple of surgeons who use the arthrogram because the most common issue with slip pinning is joint penetration. So people have looked at various ways, and I think one of the techniques described was an arthrogram, isn't it?
Yeah, as I say, I've never worked anywhere that's particularly used that, and I've never felt a need. But I guess, as I say, there's no harm in doing it. As my only caution would be to be aware that you could still be quite close, just within the thick cartilage on top of the bone.
And you told that you take the hip through the entire range of motion, so you don't use a traction table, right? You just leave it normal.
I vary a little bit actually. I quite like doing it freehand and being able to get a proper frog lateral X-ray. However, in a really unstable slip, if I was going to do that kind of pinning in situ / gentle allowed reduction, then I would put them on the traction table for that, because otherwise when you're taking the leg into the frog lateral position, every time you're moving it, if it's really unstable, it's potentially damaging the blood supply. So on the traction table, all I do is just, unlock the rotation at the end and take it through the rotation on the traction table at the end.
The other question that has come up is regarding the done osteotomy. Now, there's a lot of hype that the done osteotomy of late, because at one point of time, done went into disrepute because of the higher incidence of AVN. But of late, there is a comeback of this procedure. So what is your experience? Do you do that in your institution?
So I personally am not doing it. I've got a colleague that does. I mean, as I say, there's a bit of a variety of people, whether they do a surgical dislocation with it. And certainly some of our regional kind of centres like Leeds and Sheffield do the surgical dislocation technique. That was something that I did a bit of on my fellowship in Sydney. And I was pretty impressed with the results there. But, there are some risks. There are patients that can then get a dislocation. It was something that when we did it in Sydney, you tended to do it with 2 consultants plus a fellow. We took a lot of time over doing it. We, had a very special setup in theatre, and that wasn't something that I felt that I could necessarily replicate in our unit. And additionally, we don't see all that many. It's so specialist that you've got to make sure that you are doing enough to do that reliably. So I personally didn't feel that I do enough, and I leave those to my colleague when he's available. And if he's not available, then we would send them to Sheffield or Leeds that are doing bigger numbers.
Thank you for that. The other questions are with respect to AVN and chondrolysis. So is there a chance of getting a chondrolysis without a screw penetration? For example, you're sure that the screw has not penetrated into the joint, but is there a risk of getting chondrolysis per se? Because does slip per se predispose to chondrolysis?
As I say, the chondrolysis that I've seen have always been in association with AVN. I've certainly never seen a chondrolysis in someone with a mild slip and pinned in situ and no other problems. So I don't know. I'm not sure if it's just from the historic literature that they talk about that, or whether we're better at doing it now. I don't know. But certainly when I've seen it, it's only really been in association with AVN, and that happens at the same time the hip just all falls apart.
And the moment the cases that you've seen AVN with chondrolysis, was there a history of screw penetration into the joint?
No. I mean, I don't think there's any increased risk of AVN with screw penetration. Yeah, I don't think I don't think there'd be any link between those things.
And what do you think are the long outcomes of these issues like AV and chondrolysis? How do they fare later?
Well, the patients I've seen, it's just dreadful. I mean, we haven't got huge numbers, obviously, but you know, generally they've ended up getting referred for a hip replacement because there isn't a good, you know, the case I showed, you know, the shape of that femoral head. There's no good osteotomy I can do to do anything useful with that. And these days, with hip replacements being done younger and younger, and a lot of, you know, you obviously want to have it done by someone that does a lot of young adult hips. You know, I think that girl that I showed, you know, she was absolutely miserable, couldn't do anything. And having a hip replacement for her was absolutely transforming. And I think really that's the only option for these kids, unfortunately.
But at what age do they undergo hip replacement? What was
So
the...
as I say, I mean, obviously from the age of the slip, they usually, the slips normally had around age, you know, 12 or so on. The ones, I haven't seen many younger ones get bad AVN. So generally by the time you've gone through all these other interventions of trying EUAs and adductor releases and other things like that, by the time you get to that point, they're often nearing skeletal maturity. So as I said, I think that girl had hers when she was 14. And I think the other case I can think of would have been a similar kind of age.
And they went on to do a total hip at what age approximately?
So yeah, 13, 14 in girls.
For hip replacement, total hip.
Yeah, yeah. It's not me doing those because I don't do arthroplasty.
Yeah. So do you think that's a very young age? And do you think that there's going to be an interim procedure that could delay the total hip replacement? Because at one point of time, historically, there were a lot of osteotomies, for example, the shunt.
I think, I mean, I just, in terms of what outcome that you can offer that patient, you know, there's no osteotomy that you're going to be able to do that gives them the amount of independence and pain relief that a total hip replacement would. Now, admittedly, a total hip replacement comes with some quite considerable risks if it goes wrong, and, you know, when will it wear out and need revising? But, you know, for the vast majority of patients, that's going to give them at least 10, 20, 30 years of really good function. Compared to an osteotomy that's still going to leave them with a limp, pain, restriction of movement. So I'm not saying don't do an osteotomy. I'm sure there's people out there that do, but I think increasingly, you know, modern hip replacements are, you know, looking like a really good option.
Because the reason I asked you is because in India, we get a lot of tuberculosis hip and they get at a very young age. And this question comes up, how young do you do a hip replacement? So what a lot of surgeons do is they do a offloading osteotomy and they try to prolong the replacement as much as possible. And when she's really, really symptomatic, they do a conversion total hip. Of course, its own issues like converting a subtrochanteric osteotomy to a total hip is a very, very difficult challenge. But that's kind of an interim procedure that they do over here. And that's why I peculiarly asked about that.
I have to say I'm probably not the right person to ask that question to, really. I'm out of my comfort zone there, just because yeah, you know, I'm not an arthroplasty surgeon, and that's the kind of thing that I would refer. I can only really comment on patients that I've referred to another centre, and generally they've ended up having a hip replacement. I mean, I can't think of a child that I've had that's had it so young that really it was far too young to have a hip replacement. But you might be better asking a young adult hip surgeon or something about that.
Okay, Sally, I think we have covered almost all the questions, and I'm really glad to have you for our webinar, and it was really enlightening. You've covered everything. I don't think an FRCS candidate needs to know more about slip capital femoral. Anyone wants to go and write the exam, they just need to listen to your lecture. Thank you so much, Sally, and we look forward for more from your side because it's very, very enlightening.
Great. Thanks ever so much for letting me talk.
And we look forward for more in the future.
Okay. Thanks very much. Bye-bye.
Yeah. Bye-bye.